of cardiopulmonary bypass. That's a technique in which a machine temporarily takes over the function of the heart and lung during surgery, maintaining the circulation of blood and oxygen to the body. This step includes adding oxygen to your blood, removing carbon dioxide from your blood, and pumping this blood into your body. The abnormal physiology of cardiopulmonary bypass includes hemodilution, hypothermia, complement activation, and depression of immune mechanism. Cardiopulmonary bypass facilitates the repair of congenital heart defects in infants and children. The management of cardiopulmonary bypass for pediatric cardiac surgery is more challenging than that in adults due to the smaller size, immaturity, and complexity of the anatomy in children. Pediatric cardiopulmonary bypass circuits require a minimum of 800 and 700 cc of prime solution. Priming means the airing of CPB circuit is done by solution. It consists of a mixture of crystalloid and colloid. Priming causes hemodilution, which improves flow during hypothermia. I must point out, children have a small body weight and blood volume. So the priming volume of CPP is a relatively large volume compared with adults, about 2 or 3 times the patient's blood volume. Imagine a 3-month-old baby with a weight of 6 kilograms, has about 240 cc of circulation blood volume. Now, this volume of blood should be diluted with at least 700 cc prime solution available in the tube of the bypass machine and impose acute hemodilution that can disrupt blood supply and oxygen supply to body organs. Hemodilution is associated with many detrimental effects, such as decreased oxygen carrying capacity from a decrease in red cell value, generalized edema, reduction in plasma colloid osmotic pressure, organ dysfunction, dilution of coagulopathy, and vasodilation. The effect of hemodilution can be offset by forming the circuit with blood product. However, perioperative transfusion of blood or blood product is associated with increased morbidity and mortality after cardiac surgery. Blood transfusion are associated with several complications, including acute blood injury, anaphylactic reaction, immunological sensitization, organ dysfunction, and disease transmission. Since Paxil has been a source of bradykinin and interleukin, it can result in inflammatory reaction that can lead to post-operative complications such as longer mechanical ventilation time and ICU stay. Concern about the side of blood transfusion have led to the development of methods to preserve the blood patient. One of the ways to reduce the hemodilution rate is the use of autologous blood for priming of the circuit. In this method, a portion of the volume of the priming agent is replaced with the patient's autologous blood. And autologous priming can be made using either antegrade or retrograde method. The advantages of this method are the decreased hemodilution, reduction of the complication caused by blood transfusion, reduction of postoperative mortality, reducing the duration of ventilation, and reduction of the ICU stay. CPB created inflammatory response throughout the body. Inhalation of CPB, ischemia, and reperfusion lead to complement activation, endotoxin release, and leukocytose activation. The release of inflammatory mediator like oxygen, free radicals, cytokine like interleukin 6, interleukin 8, and TNF, collected activating factor, nitric oxide, and endothelin. This syndrome is called series after bypass. What is endothelin 1? It's the vasoconstricting agent and vessels and microvessels that produced by the vascular endothelium. Endothelin 1 is an indicator of endothelin damage in patients undergoing CPB. It causes vascular endothelial cell damage. It's produced by cytokines, acute stress, and hypoxia. Endothelial 1 can reflect indirectly the endothelial damage and determine the function of microcirculation during cardiac surgery. Excessive secretion of endothelin 1 might cause the main organ dysfunction. Some factors that stimulate to release of endothelin 1 are low shear stress, adrenaline, thrombin, hypoxia, vasopressin, interleukin 1, TNF, free radical, interleukin 6, and calcium, iron. The biological action for endothelin 1 are the regulation of vasomotor tone, vascular smooth muscle, fibrosis, cardiac hypertrophy, and inflammation. This was a cross-sectional and interventional study. A study population consists of cardiac surgical repair of congenital heart defect in pediatric patients undergoing cardiopulmonary bypass in Shahid Hospital in Shiraz City. Sampling was done randomly. 51 patients were assigned into two groups with a method of blood randomization with a blood of 4 patients, control group and experimental group. 26 patients in the control group and 25 patients in the experimental group. Inclusion criteria were children aged 1 to 10 years undergoing surgical correction of congenital cardiac disease, hemoglobin more than or equal to 10 grams per deciliter, and EF more than 35%. Exclusion criteria were history of reoperation, previous sternotomy, emergency surgery, perioperative renal failure, means creatinine greater than 1.3 milligram per deciliter, liver failure, coagulation disorder, and cardiopulmonary bypass longer than 2 hours. The data were categorized into 3 sections. Preoperative data include medicine use, biochemistry markers, and hematology index like hematocrit and hemoglobin level. Preoperative data were duration of cardiopulmonary bypass, analysis blood gas, ABG, and cross-column time, urine output value, and the amount of packed cell and blood product required, and endothelin 1. Post-operative data were the amount of bleeding and amount of packed cell and blood product consumption, ABG, output value, and endothelin 1. In this study, evaluated the blood consumption is during the operation and up to 4 hours after the completion of the procedure, hematocrit and hemoglobin level, 5 minutes after initial of CPB, after CPB, and 2 hours after CPB, and the amount of endothelin is before of the initial CPB, end of the CPB, and 6 hours and later will be recorded in both groups and will be compared together. Anesthesia induction was done midazolam, fentanyl, thiopental sodium, and etracorin, and was maintained with infusion of midazolam and fentanyl. All patients received 300 units per kilogram heparin before the bypass to make the activated coagulation time over 480 seconds in order to prime the oxygenator in both groups, crystalloid 500 to 800 milliliter ringer lactate and colloid 50 milliliter albumin, and heparin 100 unit per kilogram inside oxygenator were used during CPB heparin prescribed to achieve the target ACT. A control group, after sternotomy, the cannulation was performed and a patient connected to the CPB circuit, but the methodology for experimental group was different. After the aortic cannulation, the volume of crystalloid in the atrial line is replaced with the patient blood by the retrograde method, and the excessive volume of prime solution in the reservoir enters to the collecting bank, and then the arterial line was clamped. Also, after atrial cannulation, the venous line clamp was released, and the prime solution into the venous line was replaced with the patient blood, and the prime solution gathered to the collecting bag. This process should be done slowly to prevent hypotension and arrhythmia. And this method requires collaboration between the surgeon, anesthesiologist, and perfusionist. If the mean blood pressure reaches below 60, the inositol will require to be injected. Data were analyzed by SPSS 19 software. For studying correlation between variable Pearson test was used if there was a normal data disruption distribution pattern and experiment in the absence of a normal distribution pattern. PR30 test was used to compare two-time normal variable. Independent t-test was used for variable with normal distribution. Mann-Whitney or Wilcoxon tests were used for variable out of the normality. Chi-square test was used for comparing frequencies of qualitative variables between groups. A cross-sectional study comparing 51 candidates for correlation of congenital heart anomaly surgery in two groups was conducted. There were no significant difference in age, gender, body weight, B1 carotid, and other general information between two groups. You can see the table in this slide. There were no significant differences of CPB time, cross-clamp time, fluid administered before CPB, fluid balance during CPB, and urine volume between the two groups. The volume of intraoperative blood transfusion in the experimental group is lower than the control group, and the difference is statistically significant. There were no significant difference between blood consumption in the first 4 hours after the operation. ICU state and duration of mechanical ventilation, the two groups. The amount of intraoperative blood transfusion in experimental group was significantly lower than control group, which is 205 statistic in experimental group and 205 statistic in control group. Hemoglobin and hematocrit level in the experimental group are more than control group 5 minutes after CPB. However, there was no significant difference between the level of hemoglobin and hematocrit after the end of the bypass between two groups. Endothelin 1 in experimental group is more than control group before the start of CPB, and at the end of the CPB, the amount of endothelin 1 increased in the experimental group and decreased in the control group. There was no significant difference between two groups. Several studies have been done on the evaluation of autologous prime versus conventional prime in adult, but limited researchers are available in pediatric patients. In this study, we evaluated retrograde autologous priming in cardiopulmonary bypass during surgical correlation of congenital cardiac disease in pediatrics. According to the result, the two groups were similar in demographic factors and didn't have a statistically significant difference. Also, blood consumption in the experimental group was lower than the control group, and it was statistically significant. As a result, autologous param reduced blood consumption during surgery. The amount of hematocrit and hemoglobin at the beginning of bypass was higher in the experimental group, but after bypass and 2 hours later, it was no significant. As a result, autologous param improved blood supply and oxygen supply by preventing the forced drop of hemoglobin at the start of bypass. There was no significant in ICU stay and the duration of mechanical ventilation between two groups, which is consistent with the result of previous study. According to our finding, experimental group and increase in endothelin 1 level at the end of the cardiopulmonary bypass and the control group showed a decrease in endothelin 1 level. Of course, this difference is not significant. We assume an increased endothelin 1 level could involve several factors, such as oxidative stress and inflammatory response to the patient's own blood during while done wrap and blood contact with CPB circuit. While receptor react to decrease in pressure during wrap. There has no study on the effect of autologous param on the endothelin 1 level after CPB, so it seems this requires more research. The retrograde autologous param method in children is effective in reducing blood consumption, preventing an impulse drop in hemoglobin, improving blood supply and oxygen supply during surgery in pediatric patients undergoing cardiac surgery. Thank you for your attention. I'm here if you have a question.
Okay, thank you so much, Dr. Motahareh. That was an excellent presentation.
You're welcome.